So we now move into the next session, which is called Genotype Phenotype Correlations. And the first presenter is Elizabeth Doherty, who will talk about extracellular matrix variability in vascular EDS syndrome from the University of North Carolina.
Thank you. I am really excited to be here and present my work today. You can see my screen okay, and it's in the right view.
Yep. Yes.
Okay, perfect. So my name is Elizabeth Doherty. I am a graduate student in the Polchek Lab in the Department of Biomedical Engineering at the University of North Carolina in Chapel Hill. I am excited to present my work on extracellular matrix variability in vascular Ehlers-Danlos syndrome. So we're all aware of what vascular Ehlers-Danlos syndrome is. It's caused by autosomal dominant mutations in the COL3A1 gene, which leads to a collagen 3 reduction in the extracellular matrix and leaves patients susceptible to arterial ruptures and aneurysms. And this makes a lot of sense. The ECM provides a lot of mechanical integrity to the blood vessels, as the different materials that make up the ECM composition afford it porous and viscoelastic mechanical properties that allow it to deform in response to the pressures applied by the different phases of the cardiac cycle, and not to deform without rupture in usual circumstances. As we heard this morning from all of the great mouse models, there's been work in vivo to show functional consequences of the mutation, both in terms of mortality and also in terms of mechanical rupture forces necessary. And we're interested in looking at the specific contributions of the ECM components on these mechanical properties and VEDS disease presentation overall. And so we're trying to address the question of how ECM produced by patient-derived cells with COL3A1 mutations differs from ECM produced by healthy cells. And to do this, we have 4 different human dermal fibroblast cell lines, 1 healthy control, and then 3 VEDS patient-derived cell lines, each with a different mutation in the COL3A1 gene that result in either haploinsufficiency for the first 2 patient cell-derived lines, which we would expect to produce half the amount of healthy matrix, and 1 mutation that results in a dominant negative phenotype, which we would expect to produce ill-formed matrix. Our system that we use to study this cell-derived matrix is we plate cells on tissue culture plates and treat them with a high concentration of ascorbic acid over a 6-day period, encouraging them to produce collagen-rich matrix deposition, after which we decellularize using a detergent paste lysis buffer and treat with DNase to remove residual DNA. And we're left with this ECM scaffold that we can then characterize in terms of mechanics, production rate, structure, and content to look at an overall picture of how ECM production might differ for patient cells with VEDS mutations versus healthy control. We've seen that our cell-derived matrix can be decellularized for all of the cell lines we've used by staining for filamentous actin and DAPI as markers of cellular residue. And you can see after treatment, all staining for F-actin and DAPI is gone. However, we still see fibrous ECM components retained after decellularization using both phase contrast microscopy and confocal reflectance microscopy, indicating that we are still retaining ECM properties. Further, using confocal reflectance microscopy, we're able to obtain a measurement of thickness of our sample. And we see by measuring this over the time course of our experimental timeline that at the end of our 7-day time point, the haploinsufficient mutations produce the cell lines with the haploinsufficient mutations produce ECM that is significantly thinner than both the wild type and the dominant negative phenotype, indicating that mutations are affecting the production rates of ECM components. We use nanoindentation to probe the mechanical properties of our cell-derived matrix. So nanoindentation, briefly, this is the nanoindenter machine, works by indenting into our sample using this probe that consists of a cantilever beam with a spherical tip at the end. As you indent into your sample, this cantilever beam bends upward, and the machine detects the amount that it deflects, as well as the load being applied to perform the deflection. And then by plotting the load versus displacement along with the characteristics of the spherical probe used for indentation, we can extract a measurement of the Young's modulus, or the overall stiffness of the cell-derived matrix that has been produced. And so I've done this on samples at 25 different points for each sample for all of the cell lines to look at the difference in characteristic mechanical properties. And when we performed these measurements, we saw that the stiffness was dependent on the specific COL3A1 mutation. You can see that the two haploinsufficient lines have a significantly stiffer mechanical integrity compared to the wild type and the dominant negative. And if you look at the box and whisker plots over here, you can see they also have higher variability of the Young's modulus within the samples compared to wild type and the dominant negative. However, you'll remember that the two haploinsufficient lines were significantly thinner, and thickness can have a big impact on mechanical properties. And so we were worried that this increase in stiffness that we were seeing was artificial and a result of just having a thinner matrix. And so to account for this, we decellularized samples at day 4 of our time point for the wild type and the healthy control. The wild type and the dominant negative cell line to have a similar thickness compared to the haploinsufficient. And when we did this and acquired the Young's modulus at before, we saw that there was no significant difference in the Young's modulus measurements acquired, indicating that the thickness should not be impacting the stiffness measurements and giving us confidence that this difference in stiffness was real and a true phenotype of the CDM produced. We further want to look at viscoelastic properties, and because they show the amount of the blood vessel's ability to recover from strains due to increases in blood pressure and are extremely important for time-dependent mechanics. And so to do this, we performed a stress relaxation experiment where we indented into the sample and held that indentation for a prolonged amount of time, and then quickly released to get this characteristic stress relaxation curve, which we then used to look at the impact on the steady state versus peak stress. So the amount that the CDM was able to deform over time, and then also how long it took to get to that time point. And you can see here that the two haploinsufficient cell lines that we used produced CDM that had a similar steady state peak stress in comparison to wild type, but that the dominant negative deformed more, had a lower steady state peak stress overall. However, you'll see that the time dependence of this varied dependent on the mutation. The two haploinsufficient lines had a lower half time, so they deformed much more quickly. Whereas, although this is not significant, the dominant negative seems to have a higher half time, indicating that it took longer to deform overall. So these results overall indicated to us that there are differences in viscoelastic properties of the ECM dependent on the specific COL3A1 mutation, and they differ based on which one you're looking at. So today I've shown you that we've been able to derive cell-derived matrix that has a fibrous structure for all of the cell lines that we've looked at, and that there have been some differences in the characteristic properties we've looked at. We've seen a decrease in overall cell production for the two haploinsufficient VEDS lines, as well as an increase in the stiffness or Young's modulus of those cell lines overall. Further, when we looked at viscoelastic properties, we saw a decrease in the half-time for the two haploinsufficient lines and a decrease in stress ratio for the dominant negative line, indicating that there are differences in the viscoelastic properties, but that these differ based on the mutation overall. And so I think these results are really interesting and pose a great opportunity to look further into the heterogeneity of this disease, and potentially the mechanical mechanism of rupture may differ depending on mutation. So I'd like to thank my advisors for their help, as well as all of my lab mates, especially Wen, Stephanie, and Emily, for their help in contributing to this project. And I'd like to thank you all for listening to me. And I'd love to take any questions now, or feel free to email me after the presentation.
Well, thank you very much. And we will move on to our next one, which is by Madeline. Madeline, there you are. Is here, and we'll talk about genotype first investigation of vascular EDS phenotypes and penetrance among COL3A1 mutation carriers in an ethnically diverse biobank. She's from Mount Sinai in New York.
Hello, everyone. As said, my name is Madeline Louie. I'm a second-year medical student at Mount Sinai, and today I am presenting on a genotype-first approach to vascular Ehlers-Danlos syndrome, which I will refer to as VEDS, that reveals interesting findings on the phenotypes and penetrance of COL3A1. We have no conflicts of interest to disclose. So the literature surrounding COL3A1 related phenotypes primarily comes from studies of symptomatic patients with a clinical diagnosis of VEDS. The majority of COL3A1 mutations in known VEDS cases are glycine substitutions, splice site variants, and insertions or deletions in the triple helical domain. Previous studies have shown that the type of COL3A1 mutation an individual harbors affects his or her clinical phenotype, including median survival. Currently, the penetrance of VEDS in people with a high genetic risk profile is unknown, and there are no FDA-approved therapies. As a result, there is uncertainty in how we should properly counsel family members of probands who have COL3A1 mutations, and whether or not COL3A1 mutations should be included as secondary findings for genetic testing results indicated for other conditions. Additionally, at present, COL3A1 is listed in a list of 59 genes by the American College of Genetics considered clinically actionable. However, considering the unknowns about the penetrance of COL3A1, it is important to determine if this inclusion is clinically appropriate. The genotype-first approach identifies individuals with putatively deleterious variants in disease-associated genes, and then determines if these individuals have relevant phenotypes. This approach can help elucidate the penetrance and therefore clinical actionability of COL3A1 mutations. So the purpose of our study was to use a genotype-first approach to ascertain VEDS-associated phenotypes in biobank participants harboring putatively deleterious COL3A1 variants. For this study, we used data from Mount Sinai's BioMe biobank in New York City. This biobank links whole exome sequencing to longitudinal electronic health record data for 32,344 patients within an ethnically, socioeconomically, and medically diverse population from over 30 of Mount Sinai's medical centers. Using these exome sequences, we identified carriers of deleterious COL3A1 variants defined as missense substitutions for glycine, variants disrupting splice sites, and frameshift insertions or deletions in the triple helical domain. After we identified BioMe enrollees with potentially deleterious COL3A1 variants, we reviewed their electronic health records for phenotypes associated with VEDS. Ultimately, we identified 18 BioMe individuals, or 1 in 1,797 BioMe participants who harbored potentially deleterious COL3A1 variants. These variants included 15 glycine substitutions, 2 splicing variants, and 1 frameshift deletion. To go into the background of these patients that we identified, of the 18, 11 were female. The median age at the last electronic health record encounter for living subjects was 54 years, and the median age of death for the 3 deceased subjects was 61 years. None of these individuals had an electronic health record diagnosis of VEDS or genetic arteriopathy. Additionally, of the deceased subjects, none died of vascular, obstetric, or GI causes. And then looking at the cardiovascular evaluations, 11 of the patient had these evaluations, showing 5 with normal aortic dimensions, 5 with mildly dilated thoracic aortas, and 1 with several aneurysms in the aorta and its branches. The only other potentially relevant vascular finding was 1 patient with bilateral infrapopliteal artery stenosis. For the major VEDS criteria, 1 individual had a personal history of aneurysms and 1 individual had a family history of aneurysms. For the minor criteria, 3 people were noted to have varicosities and 1 was noted to have talipes echinovarus. Interestingly, 89% of our subjects had a history of invasive procedures or surgery, including colonoscopy, spine surgery, and invasive angiography, which would typically be contraindicated after a VEDS diagnosis. The subject who met major criteria for VEDS underwent an uncomplicated lumbar laminectomy and partial discectomy and robotic renal cyst decortication. Additionally, the 5 female subjects with obstetric histories all survived their pregnancies with an average parity of 3. And then looking now specifically at the variant types in the patients, 1 participant with a splicing variant had the history of multiple aneurysms, and then 4 participants with glycine substitutions met minor VEDS criteria for non-arterial manifestations. 2 of these 4 participants had aspartate and valine substitutions respectively, which have been previously found to be more destabilizing and associated with poor survival. Overall, our study showed that using a genotype-first approach to identifying individuals with putatively pathogenic COL3A1 variants reveals heterogeneous and milder phenotypes, and high prevalence and lower penetrance than predicted based on prior VEDS cohort studies. Previously, Dr. Byers' group estimated that VEDS has a 1 in 50,000 to 1 in 200,000 point prevalence. Our observed approximately 1 in 1,800 prevalence is far higher than previously understood. Of note, the 1 patient consistent with a VEDS diagnosis would give a point prevalence of 1 in 32,344, which would be similar to Dr. Byers' group's estimation. So thank you so much for your attention, and I'm happy to take questions now.
Well, very interesting. Thank you very much. I'm afraid that there's a lot to talk about, but we do have to move on. And the last talk in this group is by Nora Yap, who will be talking about the clinical presentation of vascular EDS in children. So extending the talk that we heard earlier in the day, not extending the talk, but extending the idea that we heard earlier in the day. So Nora?
So thank you for giving me the opportunity to present our study on clinical presentation of vascular Ehlers-Danlos syndrome in children. A bit of an introduction. We all know that vascular EDS is a rare form of connective tissue disorder caused by mutation in the COL3A1 gene with autosomal dominant inheritance. Undiagnosed, it has poor survival rate, and studies have shown that splice donor site is associated with poorer survival. Patient with vascular EDS is at high risk of arterial rupture and also hollow organ rupture. In children, the characteristic of easy bruising, thin skin, hypermobility, hip dislocation, and clubfoot are also commonly seen in other childhood disorder. Therefore, the diagnosis might be delayed. So the primary objective of our study is to describe the clinical presentation and also complication of vascular EDS in pediatric patients, focusing on major events such as the vascular events and hollow organ rupture, and also to identify associated vascular abnormalities. Our secondary aim is to determine association between life-threatening events with types of mutation in the COL3A1 gene. So we perform a retrospective study on all our patients with vascular EDS under the age of 18 years old. All patients have genetic confirmation of COL3A1 gene mutation. Their clinical presentation and findings, including whole body MRA data, were collected. In total, we identified 41 vascular EDS pediatric patients with slight male predominant. The median age at diagnosis was 7 years old, with mean follow-up of just under 5 years. Of the 41 patients, 73% were hereditary and 22% were de novo mutation. As expected, major events are more prevalent in proband and also those with de novo mutation, as opposed to those with known family history of vascular EDS. Majority of our patients were diagnosed following predictive genetic testing. 29% were diagnosed following a major event. At the mean age of presentation of 8 years, and they were diagnosed with vascular EDS a year later. So in this slide, this graph shows the different type of major events. Of the 12 patients who presented with major events, half had vascular events, and the other half had hollow organ rupture involving the GI tract and pneumothorax. Of those with vascular events, 2 had fatal aortic dissection presenting at the age of 14 and 15 years old, and both were males. One baby who also has pulmonary atresia and intact ventricular septum had an iatrogenic iliac artery rupture during cardiac intervention, resulting in neurological damage secondary to hypovolemia. One baby presented at 3 months of age with subdural hemorrhage and was initially treated as non-accidental injury and was put into foster care for 4 months before the diagnosis of vascular EDS was made. Other vascular events include right popliteal artery dissection and splenic artery dissection. In the group with hollow organ rupture, 3 babies presented within the first week of life with pneumothorax, gastric perforation, and cecal perforation. There was no age difference in presentation of vascular events and hollow organ rupture in our cohort. Our study shows that male had 4 times more major events than female. The graph on the left shows the variants of COL3A1 gene mutation in our cohort. Overall, glycine substitute is the commonest variant, followed by haploinsufficiency and splice donor sites. Other amino acid substitutes are rare. Of those with major events, 75% of the patient had glycine substitute, 17% had splice donor site, and 8% had haploinsufficiency variant of COL3A1 gene mutation. With regards to cardiac and vascular findings, 83% of our patients have normal arterial vasculature. 1 had mild aortic root dilatation, but this is in the context of congenital heart disease and previous BT shunt insertion. Only 6 patients had abnormal vasculature, with 1 patient have tortuous arterial neck vessels, 1 with aneurysm of proximal superior mesenteric arteries, 2 with mild dilatation of multiple medium and large size arteries, and 2 with dilated external and internal jugular veins. This Kaplan-Meier curve shows the event-free survival of our cohort. Majority of the event occur in early teenage years. So in conclusion, our study shows that majority of the pediatric vascular EDS are diagnosed from known family history. Of those undiagnosed, 29% presented with major and potentially life-threatening event by early teenage years. We were not able to form a true genotype-phenotype correlation in our cohort due to small number of major events. But we noted that glycine substitute is the commonest gene mutation associated with major events. Arterial vascular abnormality is rare in children. In conclusion, there is a need for development of awareness of vascular EDS and its presentation in children among healthcare caring for children in order to allow for early diagnosis and appropriate follow-up and management. Thank you very much.